welcome you all the students in e-Gurukul Pathshala. Today we have the second session on OSCE to support all the DNB exam going students. And this was offer from Baldev sir. So we all thank him and his all the way support extended to all the students. So for OSCE Spotters and Viva Station Part 2, the main participants we have are Dr. Bhavna Patil, she is a DNB student from Gandhinagar Medical College. Dr. Aarti Solanki, she is DNB student from GMERS Medical College, Sola. And Dr. Akshay Jaiswal from Nirmal Hospital, Surat, Gujarat. And Dr. Sayan Kumar Das from Gandhinagar Medical College again. So I welcome all the main participants, but I also welcome all the students who are there on the platform. And this is about the discussion, and whatever we discuss, that always stays in our mind. So please come, please go ahead in the discussion and have a nice session. I thank Dr. Baldev Prajapati sir, Guru of Guru, and always there for Gurukul. Thank you so much, sir. All the platform is yours, sir.
Yes. Thank you, Dr. Leah. As I said that to all these students, and I have selected probably exactly the questions which are commonly kept in the DNB OSCE stations. Different type of the pattern, maybe some counseling, maybe some case scenario, maybe some lab investigation, some x-rays. That's why I have not arranged some system wise. I thought that it is not better way when we are discussing. So having this idea, and even the questions also framed commonly either in the OSCE, viva, table discussion, or even in some case they may ask you. Having this introduction, let me start to share my PPT and we'll start the interactions. I think first let me, is it slide seen properly?
Yes, sir.
Okay. We'll start from where we stopped. Again, probably you can recollect the questions we discussed last time. I think from here, we'll start. You can see first the picture. This development is following the BCG vaccination in an infant. You can see the left shoulder BCG site, and at the same time, the axilla, the swelling is seen. My question is it normal or abnormal following the BCG? I think one person, please identify yourself and you can interact so that I can understand. One person, voluntarily.
Sir, Cyan, if it's less than 1 centimeter, this is BCG 1890s. If
The
it's
question is it normal or abnormal?
Normal, sir.
Okay, this which is seen is normal. Then when do you call it the abnormal?
If it's more than 1 centimeter, sir.
Okay.
If lateral axillary lymph node more than 1 centimeter, or if there is any suppurations or abscess formation, then it can be called abnormal.
First, can you describe what is the normal BCG reaction?
Sir, after the following BCG, there will be in 30 minutes, there will be a wheel formation, which may be called at PUD orange for appearance. which describes like hair follicles, the surroundings of a orange.
Okay.
Within 30 minutes, it will be there, sir. Then there will be no such any change of size and shape. And then for 1 to 2 weeks, it will be a papule formation, approximately 4 millimeter in size. From 5 to 6 weeks, 4 to 8 millimeter size will be increased. Then there will be formation of pustules, which gradually ulcerates and formation of scabs, and ultimately tiny scar formation, sir.
Okay. Let me say, what is normal BCG reaction? I think some of the aspect what he described was right. After giving, it is by intradermal route. On the left shoulder, it is given. Left shoulder just for the uniformity, no any specific reason for the anatomical constant of the left side. After this intradermal, there will be wheel of 5 millimeter at the injection site. And that is very classical. Appearance will be PDO orange. That is the dry peel of this orange. And that pitting which is seen is due to the hair follicles. What he was telling is right. But this will subside within 30 minutes. Will appear immediately. It will subside within 30 minutes. Then nothing is there. Then the papule will be formed after 2 to 3 weeks. And then it will be the pustule. It bursts open, even gets sealed off, and may be repeated for 2 to 3 times. Then there is ulceration, scab formation, scab follow-up, and the superficial tiny scar of few millimeter size. This is very classical BCG reaction. But please remember, in all the patients, this type of classical reaction may not be there. But directly there may be some scar or something that is also normal. Okay. I think my upper question is blurred because due to this, yes, okay. When this type of the complication is common for a BCG vaccination, what already described that this is the axillary lymph node will be there and there's some complication. What we say BCG adenitis in short. Who will answer? Please, I think then I will to speak. The Bharna, what is your answer? When this type of the BCG adenitis complication will follow?
Sir, this is Akshay Jaiswal.
Sorry?
Sir, Akshay Jaiswal.
Yes,
sir,
Akshay.
Sir, when instead of intradermal, we give injection by mistake, subcutaneous injection is given.
Very good.
This type of complication follows.
Yeah. Ipsilateral axillary or cervical lymph node, already what Sir was talking, less than 1 centimeter size may develop, may remain for a few weeks or months, and nothing is to be done. Right? But even it subsides by itself, nothing, no even antidote therapy. But this complication, BCG adenitis, is following subcutaneous. Line of treatment? Yes, Akshay, can you continue?
Sir, usually no treatment is required, sir.
Okay.
If it is suppuration is there, drainage can be done, sir.
Okay, very, very, very nice. Lymph node size usually more than 1 centimeter and even suppuration, abscess formation. Then you go for aspiration, which may require repeated aspiration. Sometimes surgical excision, but no anti-tumoral therapy. Any role of antibiotics?
No, sir.
No, that's good. So BCG adenitis is more common with subcutaneous. What he was talking, Akshay was right. And no anti-tuberculous drugs or no antibiotics, nothing is required. Next question. I think that is pertaining to Down syndrome, which is very common in your exam. What is the commonest genetic cause of intellectual disability? Already answer is there, right? It is Down syndrome. And that is in 20 to 30% cases with intellectual disability that is contributed by Down. Now, who will take this answer? This is very common. Various types of karyotyping in Down syndrome.
Trisomy 21, Robertsonian translocation.
Okay. Now speaking.
Yes.
Okay. Even speak your name so that others come to know, I come to know, please. And that is even tradition also in the conference that give your identity, right? Very good. Yes, Bhavna, continue. What is the most common?
Time, sir. Mutic non-disjunction.
Sorry, sir.
A mutic non-disjunction, sir.
Okay. That is the most common. Then what are the other types?
Mosaicism, Robertsonian
Mosaicism.
translocation, sir.
Okay.
4% and 1%.
Always answer in the most common, then less common, and then rare.
Mutic non-disjunction, sir, 90% around, and 4 to 5% Robertsonian mosaicism less than 2 or 1%.
Any question, please remember in this way. Anyway, here, it is the non-disjunction. It is exactly by the wording non-disjunction. That is the first junction. Then with the meiosis disjunction. If there is no disjunction, that is the non-disjunction. That type of the perfect wording they have prepared. Here we know that is the extra chromosome from mother. It is always from mother due to failure of the separation of the chromosome during the meiosis, and more common with the advanced maternal age. So this is the reason why this Down syndrome is common after the advanced maternal age. 4% is the translocation. What is translocation? That is the chromosome 21 is translocated to any of the D group chromosome, 13, 14, 15, or even G group 21 and 22. That is translocation. And mosaic, that what happens that the many cells will be normal and even few will be abnormal. It's the mixture. On the contrary, very few will be the abnormal, and that is the mosaic. So that is only 1% of the total cases of Down syndrome. This is very common question in the viva or even in the case or anywhere. Okay, next question. In which type of Down syndrome karyotyping of parents is necessary? Akshay? Which type? Already we discussed 3 times. Yes? Yes?
Sir, myself, Dr. Aarti.
Aarti, come on.
Sir, in translocation, parents' karyotyping is necessary because one of the parent can be carrier in that state.
Very good, very good. Yes. So the Down syndrome caused due to the translocation. One of the parents may be a carrier of a parent's translocation. And here, remember, risk of Down syndrome in the offspring of a translocation carrier, if mother, then 10 to 15%. And the father is carrier, it is less, 1 to 5%. Next question, what is the risk of trisomy 21 in the offspring of a woman with trisomy 21? Already mother is, that means mother is a case of Down syndrome. Then
Science at 30%.
Yes, come on.
Science at 30%.
Sign, okay, 30%, very good. Next question, what is the risk of trisomy 21 in the offspring of a male with trisomy 21? That father is Down syndrome.
Science, sir, father,
Sir,
men are
can I-
infertile, sir. Men are
Yeah.
infertile.
Okay.
Men are infertile, so
0%.
there is
Very good, Aarti. Please, I think both of you are right. And that's the thing that usually males with this trisomy 21, they are infertile. Most of the times, please remember. Now, what are the problems or diseases associated with Down syndrome?
Dr.
Bhavna?
Bhavna,
Yes.
deafness, atlantoaxial disability,
Yeah,
the hypothyroidism,
Very good.
leukemia.
okay. Hypothyroidism, yes. Deafness is good. Leukemia, even epilepsy. Very good. Good answer. Rajat, even all of you can participate. Everybody, please just speak your name and you can answer. I want the responses from multiple students. Now, risk of giving the birth to a child with Down syndrome with increasing maternal age. Just I will answer. Please remember. At 20 years, it is almost 1 in 2000. 25, almost 1 in 1200. Then 30, almost around 1000, you can say. This is the perfect figure, but I think if I answer in this way, not wrong. 35, that is very important. It increases 1 to 36.5. And 40, almost 1 in 100. And after 45, quite high. So this is, in short, you can remember that with the maternal age, what are the chances of the Down syndrome? Okay. Why chromosomal analysis of every child with Down syndrome is necessary, even if the diagnosis is clinically obvious? Rajat, are you there?
Yes, sir.
Yes. Do you know this question or somebody else even? Why? That means somebody will ask this. Already it is obvious. All the features are there of Down syndrome.
Sir, because if the case of Down syndrome is because of chromosomal translocation, then we'll have to screen the parents as well.
Very good. So depending upon the chromosome abnormality, carrier status, and please remember this is somehow most of the people are not aware of it. Now the what points to be checked or assessed during follow-up of a child with Down syndrome? Aarti? Already many points are discussed. Yes.
Sir, regular checkup of thyroid. Once it is checked in infancy, then every 3 years we can do
Very
ophthalmic
good.
checkup, sir. Checkup for leukemia.
Ophthalmic checkup for what? What you want to see?
Brush field spots, sir. Sign.
I think breast field spot, okay, it was there. How it makes difference?
Sir, cataract.
Yeah, cataract is very important. So cataract should be checked. Leukemia should be checked. Absolutely. Thyroid functioning because, you know, 15,
Hearing
20%.
evaluation with OAE and then BERA, hearing screening.
Yeah, hearing screening.
X-ray
Absolutely.
spine,
X-ray for
X-ray cervical
axial
spine.
joint
Very
instability.
good. Very good. Very good. So most of the points are covered. I may not go into details, but these are the points. Please keep in mind. Okay, now the next question. A 32 years old pregnant lady is at 20 weeks of gestation. She is referred for triple test. Now, what are the components of triple test? Bhavna, what are the triple test components?
HCG, inhibin A,
Yes,
AFP, alpha fetoprotein.
alpha fetoprotein, SCGN,
Ethylene estradiol,
Inhibin
sir. RP.
yeah, estradiol. Now, what constitutes an abnormal test of which disease do they screen for? So, please remember, maternal serum alpha fetoprotein, and it will be low in a case of Down syndrome. You know, in other conditions in pediatric practice, alpha fetoprotein is high. Suppose neural tube defect, right? Hepatoblastoma. In all these conditions, alpha fetoprotein is raised. But maternal serum alpha fetoprotein with Down, it is low. Unconjugated estradiol will be high. 3-beta SCG will be high. Triple test is used to screen for fetal trisomic chromosomal anomalies. Okay. Next question. Name the 3 radiological findings. Radiological finding that suggests the presence of the disease, Down syndrome. Antenatally.
Sir, Rajat.
Yes,
increase,
Rajat.
Sir, absence of the nasal bone or hypoplasia of the nasal bone. Then we can get the double bubble if there's a duodenal atresia. Then nuchal fold thickness would be increased more than 6 mm.
Right.
Anyway, nuchal translucency.
Anyway, points are covered. So to save the time, I go. Increase nuchal fold thickness. Please remember, short femur and femur, even the femur and the humerus. These bones will be short. That is very important criteria. Duodenal atresia and even the first trimester nuchal fold thickness and nasal bone evaluation. Okay, how can a definitive diagnosis can be offered at this stage?
Sir, may I?
Yes, yes.
Sir, karyotyping by amniocentesis.
Very good. Very good. So, you know, please remember any question of the Down syndrome, don't miss it. Because it is very common question. Either it may be in the OSCE or maybe some case or somewhere at least they are going to ask you. Anyway, I go further now. You know, asplenia is also the condition in the practice. Then chemoprophylaxis in children with asplenia. Akshat, can you take it? I hope that I spoke the right name or
Penicillin G.
Yeah, Akshay, yes. Okay. Anything else? You know, penicillin G is not the right answer. Commonly because people are using, but it's not the right one. Yes.
Sir, Sayan, it indicated in suppose sickle cell disease, asplenia, or splenectomy, and chemoprophylactic drugs like benzathine penicillin.
Sir, penicillin V is given for.
Yes, I think penicillin V. Who said? Aarti said.
Yes, sir.
Okay.
Penicillin V.
Please remember for the chemoprophylaxis. Number 1. Asplenia increases the fulminant septicemia. Mortality from septicemia increased 50-fold. Sorry, I think Okay. Following the splenectomy for trauma and 350-fold due to the sickle disease. Please remember why the difference is there. Due to the trauma or spleen rupture, suppose if you remove the spleen, that means the spleen was healthy. And healthy spleen will even create the good immunity. So there is some protection. But suppose the sickle cell disease, thalassemia, or some patients who is suffering from some disease, that spleen is not healthy and therefore no good natural immunity. Therefore, risk is more following the sickle cell or thalassemia-like conditions. And indications for this prophylaxis, sickle cell, splenectomy following trauma, even asplenic child with malignancy or thalassemia, or even sometimes congenital asplenia. This is just to add to your knowledge. Answer is, in addition, please remember that the polysaccharide vaccines are must, and that is pneumococcal and meningococcal. Drugs point of view, penicillin V, that is the long acting, and dose is 125 milligram BD in less than 5 years, and more than 5 years, 250 milligram BD. Duration point of view, the people say at least 5 years of age or 5 years after the surgical removal, whichever is longer. But ideal answer is lifetime, because we don't know. But what the people say that after 5 years, least chances that person is going to get the sepsis. But still possibility is there, and it is fatal. Therefore, ideally the answer should be for the lifetime. Now the next question. I think diagnosis is obvious. Yes, Bhavna, what is your diagnosis?
Dacrocystitis.
Congenital
Dacrocystitis.
dacrocystitis.
Very good, very good. It's a dacrocystitis. And what is the primary etiology?
NLD
I-
obstruction,
Blockage
sir.
of nasolacrimal
NLD
duct.
obstruction.
Okay, nasolacrimal duct obstruction. And manage particularly, suppose, how will you manage now this patient?
Sir, Cheyenne reassurance followed
Yes.
by Kriegler messaging up to 6 months of age, then Bowen probing. If it's not cured, then
But Sayan, already you can see here, there is a sepsis already
Sir,
almost.
local
local
antibiotic
antibiotic drops,
drops may
local
require in
antibiotic
this
drops.
condition.
Local antibiotic drops to subside the abscess.
How the local antibiotic is going to work here? If the really
Drops, eye drops, sir.
really sepsis, then we should go even for the oral or even the nasolacrimal duct massage later on. And if they were abscess formation,
Then
INT,
systemic antibiotics, IV
and then
antibiotics.
you'll have to go for systemic antibiotics. Okay. A 3-year-old boy present with sudden severe scrotal pain and swelling on the left side. You can see this was the real case. And the cremastic reflex is absent. What is the diagnosis, Arti?
Sir, torsion of testes.
Very good, very good. Torsion of testes. And what? Suppose if you suspected torsion of testes, what test you will do?
So Doppler.
Very good. Doppler is to be done. That will give you the idea regarding the blood flow. And actually, that is very important, that what delaying the treatment will decrease the survival of the testis.
More than
30 minutes. More than 6 hours.
Yes, more than 6 hours, then it will cause the permanent damage. So it is very dire emergency. Earliest it should be managed. And next question, what contralated testis need further care?
Total
So,
orchideopexy,
needs
sir.
to be done.
Yeah, it should be fixed. Otherwise, there are chances that it will go again for the torsion of testis. These type of the cases people are going to keep you. Okay, a 20-year-old child presented with staccato cough and sticky eyes. There was no fever. Child was non-toxic. Auscultation of chest revealed fine crackles. Bhavna, what is your diagnosis?
Chlamydia.
Very good. Chlamydia. Why chlamydia? What are the points favoring?
Staccato cough and non-toxic look.
Absolutely. Usually it is the
Sticky eyes.
opportunistic organism. Please, I think there was some question regarding the cough in the chlamydial infection and the pertussis. Pertussis is quite different. If you see the pertussis cough, it is the paroxysmal, it's almost continuous, and that cough is followed by whoop or even sometimes apnea, and therefore the baby may develop the cyanosis or even the occasionally seizures. So that is quite serious condition. In staccato, the cough is like, I hope that you know what is the staccato. What is the meaning, Sam? What do you mean by this staccato? Rajat, anybody? Nobody. You know, it is a very classically parrot's voice point of view. So that type of the voice will be there. And sticky eyes is very characteristic. And here, this chest size will be the minimum. Next question is, what findings are expected in chest X-ray of this patient?
Hyperinflation.
Why?
Bilateral infiltrates.
diffuse infiltrate,
Infiltrates.
Yeah, please remember, these are the non-specific. Minimal interstitial or alveolar infiltrates. And what is the choice of
Macrolides.
antibiotic?
Macrolides.
macrolides.
Macrolides. Okay. Now, next question. I hope that I would like to recollect that what are the names. One is the Sam, Aarti, Bhavna, Akshay. Am I right? And even
Yes.
Rajat and other students are also there. Please, I hope that you even participate others also with your name so that I can recollect, and I want that everybody should be there to participate and to answer. Now, I think this counseling by Aarti, a 7-year-old boy has been diagnosed as nephrotic syndrome. He has been started on steroids and has started showing the response. Now he's about to be discharged from the hospital. Now you have to counsel to the parents regarding the management at home, or what you will explain to the parents. Aarti.
Sir, first of all, we'll develop rapport with the patient, and in
Very good.
whatever language patient is comfortable, we'll speak in that. We'll explain that the medicines already has been started, and the swelling will gradually decrease. Then it will take a few weeks, and they have to monitor regular urine protein checkup. Then we'll explain some side effects of steroids also, that there will be swelling of face or weight gain will be there. And if swelling is swelling will take 1 to 2 weeks to decrease completely. And if swelling is again increasing, we'll counsel them to check urine protein and come back to us if required.
Okay. Anybody else?
Sir, Rajat.
Yes, Rajat, only remaining points. What she has
Yeah.
already mentioned, don't repeat it.
So we also need to emphasize on the like the compliance to the treatment.
Okay.
That as advised, they have to take the medications regularly and not miss the dose.
Okay.
Then the child should preferably wear mask while going in the crowd, and
Okay.
maintain safe distance from other people, like if they are having any cough, cold. Then the important part will be regarding vaccination also.
Very good. Very good.
Very
That's the important point.
So at
Yes.
least for 6 weeks after stopping the steroid, the live vaccine shouldn't be live vaccine should be taken only after 4 to 6 weeks after stopping the steroid.
Right. I think
And,
what are the yes. Sir.
Yes, science are pneumococcal,
Yes,
HIV, and meningococcal vaccines.
Absolutely, absolutely. What was my point? That keep in mind that first here you should explain regarding the disease, that what is the nephrotic syndrome. Second thing you should explain, probably the Aarti, once you are discharging, then probably the swelling must have been disappeared. Already patient must be in the remission. Then probably we discharge. After this nephrotic syndrome explanation, of course, you said, all of you absolutely right regarding the compliance, doses, don't increase, don't decrease, everything we'll have to say. And the very important point, sometimes they stop by their own. Or somebody said that it's just steroids, don't give the long time. So that we'll have to explain that whatever the duration, 6 weeks was the first episode, we'll have to explain. Then the regular follow-up. Then even they should follow for, even you should explain regarding the steroid toxicity. Very nicely you say. And of course, regarding this vaccination and everything, just to recollect the name, absolutely that how you can explain this nephrotic syndrome? You can say that this is a kidney problem. It's a kidney is doing the work of the filter in our body. But after filtering, whatever the elements or required factors or substances useful to the body, they are taken up back. But somehow in this disease, the protein is not taken up, and therefore the protein is lost in the urine. And due to the lack of the protein, this protein decreases in our body, and due to the decrease this protein, the edema develops or the swelling develops. And that's the whole mechanism of nephrotic syndrome. And for that reason, steroid is the only answer. Fortunately, you can say that in most of the children, they are responding to the steroids, they are steroid responsive. So they usually do they have a good response. So don't worry. The only thing you should explain for the relapses also. Otherwise what the parents will develop the problem that already it was okay, now again they develop. And suppose if you have put the word that even the relapse can occur, their anxiety will not be there. That of course, even after this treatment also, some children may go for, again they can develop, but we can manage. And on this type of how many times they can develop, we are not sure. But every time if you manage properly, later on as they grow, probably most of the children, they don't remain the problem. And even there is no any permanent damage to the kidneys that we can explain. Of course, your toxicity and everything you have said, so I may not repeat it. That is very important. Even here, ask the mother to prepare this note or diary. In such conditions, always mention the diary. Suppose a case of bronchial asthma, a case of nephrotic syndrome, a case of epilepsy, a case of ITP, because here there is sometimes long treatment we are giving, and relapses are also is going to happen. So if the proper record is there, that will help you for further management, even to some other consultant, suppose by chance if they go to somebody else. So these are the things. And vaccine, live vaccines during the nephrotic syndrome, no. But suppose some vaccine is to be given due to some epidemic problem, then killed vaccines can be given. Of course, the effect will be less. And after 6 weeks of the discontinue the steroids, pneumococcal, Hib and meningococcal vaccines are very important. So I think these are the points to be covered. In this counseling, what is my idea? You should have the points in your mind that what is to be discussed with the parents. What is your idea? So that you should not miss it. Okay, now further. I think sometimes somebody will ask with this intramuscular injection. Yes, Akshat, what is the preferred sites for intramuscular injection at different ages? Akshay? Suppose 6-month-old child, where you are even going for the primary DPT vaccines.
Enterolateral aspect of thigh.
Okay, where is the enterolateral aspect of thigh? Anatomically, how will you decide?
Medial third and vastus
Vastus
lateralis.
But there is not written on the thigh that this is vastus lateralis. So the point is
The
anatomically how will
medial
you
thirds
decide?
are between greater trochanter and lateral femur condyles that drawing a line in
And
the
greater
middle.
trochanter is a part of which bone?
Greater trochanter is a part of, the hip bone. Knee, it's femur. Femur, sir.
Some different answers are there. I think you are not sure.
Femur.
Greater trochanter is the part of femur. And lateral condyle?
Tibia.
That's why I ask you. Lateral condyle will also be the part of femur. We are not going for this tibia. So the point is anatomically, greater trochanter and lateral condyles, these are the two anatomical landmarks. Draw the line and take the middle 1/3 of it on the anterolateral aspect of thigh. This is a very proper, and of course the targeted muscle is the vastus lateralis. And what are the different ages? Middle third of the anterolateral we discussed, more than 3 years even, ideally more than 5 years, but of course book mentioned more than 3 years. Practically I will say after 5 years I can go to the deltoid. And never the gluteal region. Which vaccines they have studied that even all the doses, if you complete, then also there is no any effect.
Hepatitis B and rabies.
Yeah, and even the rabies. They have found that's therefore even the no vaccine should be given on gluteal region. Which muscles already we discussed? How will you decide anatomically for anterotal thigh deltoid injection? Already we had discussed, right? Deltoid even how will you decide? Midway between the acromion process and deltoid insertion, because that is a very safe area where probably will not injure. Otherwise, you know that all the vessels, nerves will be passing through the groove in the humerus. Now, next question. A 6-year-old child presents with muscle cramps on exercise with urine test positive for myoglobinuria and CPK is raised and has been found more particularly after this exercise. Arti, any idea?
Myocardial.
Glycogen storage myocardial.
Very good. It's a myocardial disease type 5 glycogen storage disease. What is the enzyme?
Muscle
phosphorylase.
Muscle phosphorylase deficiency. Name the type of this disorder presenting with hypertrophic cardiomyopathy in infancy.
Type 2
Pompey's disease.
Yeah, Pompey's. Pompey's is another name. Absolutely, type 2. Now, please, another variety of the question. And this is again the common question which the people are going to ask you. Even sometimes the OSCE, once or twice I have seen that they have asked in the last 5 years. I hope that who are the other students, please? Name yourself before I go for the question. You know, here the 18-month-old child present with severe pallor. Now, that means anemia. Take the history in details from the mother. That means what are the points you are going to ask you? Yes, so Bhavna, can you take it?
Yes, sir. First, beginning from the antenatal history, did the mother receive iron and folic acid preparation during the all trimesters? And is there the birth spacing was adequate? And what was the mother's hemoglobin during the antenatal period? Then after birth, was breastfeeding initiated and baby was exclusively breastfed, and when was complementary feed introduced? Then is there was any history of worm infestation?
Okay. Anything else?
And if the mother is strictly vegetarian, if
Very
ruled
good.
out vitamin B12.
Okay, fine.
And knuckle pigmentation history.
Okay.
And
Here-
antepartum hemorrhage history is there or not?
Okay. Anybody else wants to add something?
Signs or history of any blood transfusion, any
Okay.
recurrent abortions in the mother.
Very good, very good, very good. Your transfusion, that means hemolytic anemia, how we'll come to know? Absolutely. Good. Anything else?
So whether the onset of pallor
Similar
is
problem
sudden
in the
or gradual,
siblings.
or child is
That is
pallor.
also very good. Yes. How the onsets, that was it suddenly or gradually? Okay. Anything else?
Any drug, sir, sign any drug.
Drug is also very important. Absolutely.
Then sibling history, similar history in the siblings.
Right. Anything else in further family history?
Petechies or purpuras, anything, or presence of jaundice
History
or
of
not?
sir jaundice,
Jaundice, yes. Right. So many points. The point is, for anemia, what are the points which you can gather in the history, which will help you to consider or to exclude various etiological conditions. So the point is here, yes, rep and everything. That history in details is very important. Of course, the onset is sudden or gradual. Suggesting the worms, I think Bhavna mentioned. History of bleeding or blue spots, yes, I think Aarti told. Then ask for any drug for longer duration, particularly aspirin in a case of Kawasaki. Associated symptoms like fever and weight loss, which may be due to malignancy. Jaundice is very important. Blood transfusion, yes. Similar problem in the family. Even consanguinity. And geographical and family background also is very important. Okay, now Aarti, explain the urine sample collection by the clean catch midstream in a suspected case of ETI.
Sir, preferred morning sample. First of all, we'll explain to mother that the local part should be washed with plain water without any soap or anything. Then the urine first morning sample is preferred. Initial few drops of urine should be discarded, and then a sample of urine should be collected directly in the container, and then it should be sent as soon as possible to the lab. If not, then it should be kept in refrigerator.
How much at what temperature?
And 4 degrees, sir. It's 4 degree around.
Yeah. Anyway, I think very nicely she said. Some of the points, please remember. Genitalia should be cleaned with soap and water. Antiseptic washes and force prepuces retraction is not advisable. That we'll have to positively explain to the mother. As possible, child is older one in the squatting posture, that's good. Then retract the prepuces skin and separate the labia in a female, and then ask to void the urine, so that lesser the chances of again the contamination. Discard the initial part of the urine. Mid part of the urine should be collected, not few drops only, because the initial part of the urine, and sterile container, plating of the urine specimen within 1 hour, and if requires, it is to be kept in refrigerator at 4 degree or 2 to 8 degree. So I think very nicely she did. Okay, one more question. Already I think answers and everything has come. 3 months old child, referred for frequency of stool 15 to 20 times since birth, and birth weight was 2.9. He was found with severe dehydration, hypokalemia, hypochloremia, metabolic necrosis. Please remember the case scenario: chloride losing, diarrhea, very rare, but yes, it can occur, and the condition is due to the defective transport mechanism of chloride or bicarbonate at the distal ileum and colon. And there may be the polyhydramnios in the pregnancy. Anyway, a 2-year-old girl presents with the ecchymotic patches off and on since birth, and there is past history of prolonged umbilical stump bleeding and delayed separation of umbilical cord. Yes, sir.
Yes,
What-
sir.
what
FSF, fibrin stabilizing factor 13 deficiency.
Factor
Okay.
13.
Okay, now Aarti, next question. What is the another attention drawing clinical manifestation of this disease after surgery?
Sir, poor wound healing.
Very good. Or wound healing. And what observation, Bhavna, is the basis for screening test for deficiency of this factor? What observation is the basis for screening test for deficiency of this factor?
Science,
Anybody?
Science, sir, it's clot, some deficiency of the clotting factors.
Instability of the clot, that is very important. And what pattern of hemorrhage makes the clinician to suspect this condition, Akshay? What is the pattern of hemorrhage?
Sir,
Yes.
late
Science,
presentation.
slow, delayed. Science and slow, delayed.
hemorrhage.
Very good, very good, very good. You know, it's a delayed hemorrhage. Most of the times what happens, that trauma and bleeding. But suppose trauma was yesterday and later on there is bruise or hematoma. That is a very, very classical story. And define the delayed separation of the umbilical stem.
Science 28 days.
Okay.
4 weeks or 20 days.
Ideally 4 weeks of age. Most of the, what is the common time for the separation of this umbilical cord?
7 to 10 days, sir.
7 to 10 days.
Yeah, absolutely.
Sir,
Yes. Yes,
sir, I
Ratan.
had one doubt. So in
Go
the
ahead.
previous slide, the case scenario where the child presented with diarrhea and hypokalemic metabolic alkalosis.
Yeah.
So why it can't be a tubulopathy like Bartus? Like how we differentiate based on those?
I will come to the point. I think after this, yes. Here, you know, the 3 months old child is referred for frequency of stool. In Bartter syndrome, hardly the frequency of stool will be there. And this stool is watery since birth. That is the attention how the patient presented. Of course, anything can be there with the metabolic alkalosis and hypokalemia and hypochloremia. But when the presentation since birth is watery stool, which is never, I will say, the common, even in any other disease also. And that makes it very, very, how the Bartter will present. Barter will present with just failure to thrive and polyuria, not the frequency of stool, that to watery 50 to 20 times. So with that case scenario, and I think here even in the exam also, please, therefore you read it. I know that sometimes the people will, with the hypokalemia, metalocrosis, they write out the Barter one. But you know, every time, even sometimes the Barter-like picture I may give in a case of cystic fibrosis also.
Received Barter.
So what I mean to say, there is also the metabolic alkalosis and hypochloremia. But therefore, always read the detailed story, that what type the story is given, problem is given to the patient. Here, in all the conditions, chloride is lost. That is the basic cause. Here, chloride is lost in the diarrhea, GI tract. In a case of cystic fibrosis, chloride is lost in sweat. In a case of Bartter syndrome, chloride is lost in urine. Right. This is the basic difference. I will listen to all the three conditions. Of course, they are going to present with the metabolic alkalosis, say, and hypochloremia and hypokalemia. Right. So I think again, Rajat, you asked a good question. In any case scenario, please keep in mind, and in OSCE, it happens so. If you don't read it, many and they will be the tricky question even, because they want to create the problem for the students. So always read the question in detail. Don't jump because something is in your mind. It is very, I would say, common for every human being. And then we may maybe be wrong. So with what reference this classical, some investigations or something is given, I think Rajat has raised a very good question. So that I clarified for any question, not only for this, but any question. Okay. Now here, 3-year-old girl referred for precocious puberty and obesity. And even the gelastic seizures, Aarti.
Sir, hypothalamic hematoma.
Okay, what is the gelastic seizure?
Sir, different type of laughing,
Yeah.
unusual laughing. Or
Emotional outbursts without any reason. Hypothalamic hematoma. And you know, please remember that hypothalamic hematoma is more common in the girls. And it is the most common cause for the precocious puberty. And clinical gelastic seizures, unnatural crying or laughing. What are the other clinical manifestations of this disorder? Hypothalamic hematoma?
Diabetes insipidus, sir.
Very good, very good. Because hypothalamus is involved, then what are the other problems?
Obesity.
Even the hyperthermia, cachexia. Hypothalamus is responsible for cachexia also. What type of sexual precocity is known to occur in this disorder?
Cyan isosexual.
isosexual.
Absolutely, absolutely good. Okay. A long-faced 10-year-old mentally retarded boy presents with prominent ears and large testes.
Fragile X.
Fragile X and
Fragile X, yes. The question is, what causes the feminization of these boys?
aromatase
enzyme.
Aromatase enzyme.
increase.
Excessive production of aromatase, yes. Name the other two conditions associated with testicular enlargement.
HSP. Sir.
Okay. Okay, sir, anything else? Anybody else?
Lymphectasia, sir.
Lymphangioma.
Very good, very good. HSP and lymphangiectasis. Okay. Now, please remember that for the boys, particularly older boys, mental retardation, this is the most common cause of Fragile X syndrome. And nowadays, we are able to diagnose genetically and we can confirm it. So I think somebody may ask even the further questions. A 7-year-old boy, child presents with repeated episodes of non-pitting edema and abdominal cramps. His parents are told that this child is having the immunological disorder. What is that disorder? Bhavna, any idea?
Complement factor deficiency.
Okay, which one?
C1.
C1
inhibitor.
C1 inhibitor. I think in the last session also we had one case. Different case. What complication can be fatal in this condition? What complication is going to be fatal? That it will kill the patient.
Some laryngeal
Angioedema.
edema.
Absolutely, laryngeal edema.
Leg-
And then third question, which other disorders have been reported in these patients?
Glomerulonephritis, sir, one.
SLE. SLE.
Okay,
Glomerulonephritis, sir.
SL and glomerulonephritis. Okay. A known case of Hodgkin lymphoma present with sudden onset of cough, dyspnea, hoarseness of voice, stridor, facial edema, and drowsiness. All these problems develop within few hours. What is the complication?
Superior
vena cava
SBC,
syndrome.
SBC compression.
SVC obstruction.
Absolutely, superior vena cava compression syndrome. And what are the life-saving modalities of the treatment? What we can do immediately to save the life?
Steroid.
Okay. Anybody else? Chemotherapy and radiotherapy. Steroids will take time. People say radiotherapy, but chemotherapy should come to next. A 2-month-old child presented with marked respiratory distress since birth. This is the X-ray. Bhavna. Akshay.
Sign, sir.
Sir,
Yes, sir.
emphysema.
Congenital, sir, left upper lobe emphysema. Congenital, most likely.
Okay.
Considering the age of the patient.
Okay. Arti, would
No.
you like to differ? Rajat? Anyway, suppose somebody asks, what are the findings? What you are able to see in this X-ray?
The deviation towards the right side and
Yes, very good, very good. Mediastinum is shifted on the opposite side. But
And
if you
there is
see,
Hyperlucency of the left
translucency
upper lobe.
left upper
absolutely,
lobe.
very
And
good.
age of the patient is also more likely congenital.
Yes, so it is the congenital lobar emphysema on the left side. What is the new name now? I've also forgotten. Please check in the 21st edition of Nelson. They given some new name to this condition. What is the most common site of this lesion?
Left upper lobe.
Yes, left upper lobe. What is the line of the treatment?
It has to be surgery, sir, excision.
Yeah, absolutely, excision of the affected side. Here, 9-year-old girl with a high-grade fever of 4 weeks duration, it was diagnosed as brucellosis. And now she started to deteriorate with high-grade fever, pancytopenia. Bone marrow aspiration confirmed the diagnosis, and this is the picture. Bhavna?
HLH.
HLH.
Okay, that is infection-associated HLH. Please remember, the secondary HLH, this is the right. Primary familial is different. Okay. Name other 2 blood investigations including diagnostic criteria of the condition.
The sign fibrinogen less than 150 around and triglyceride more than 500. 250.
So increase
250.
ferritin levels,
Ferritin
hyperferritin.
level.
Triglyceride and fibrinogen, sir.
Yeah. Please remember, triglycerides more than 260, fibrinogen less than 150, ferritin more than 500. Okay. What other changes you may see in the acute phase reactants?
Interleukin
So
6
ESR will be on a lower
interleukin
side
6
because
will
of
be raised, sir.
fibrinogen deficit.
Sorry,
So
Rajat?
Interleukin.
ESR will be low due to hypofibrinogenemia.
Yeah, here please remember that interleukin, the cytokines changes are going to be there. But how it is reflected in our routine investigation, because fibrinogen decrease, ESR is going to go down.
Yes.
And CRP is increasing. That's how it's a marker which will give the important clue. Name other similar syndrome with autoimmune disease like Sogia.
Mass. Macrophage activation
Macrophage
syndrome.
activation syndrome. Yes. Now one more X-ray. 5-year-old child brought with complaints of cough, chest pain, and no fever. Anyone the hemoptysis. This is the X-ray.
Right-sided hydrated cyst.
Okay. What is the medicine can be given in such cases?
Albendazole, sir. 15 mg per kg per day in 2 divided doses.
For how much time?
Sir, for 3 to 6 months. 6 months and on.
Okay. Name the causing agent.
Agranulococcus.
Echinococcus granulosus.
Echinococcus granulosus.
Echinococcus granulosus.
Okay, echinogranulosus is classified where in the parasitology? That
It's a
is what
hepatic
type?
fluke, sir. Hepatic fluke.
Is it hepatic fluke? Is it?
In trematode.
Nematode.
Trematode.
Okay,
Nematode.
is it? Please remember in the parasitology, common is protozoa. Protozoa are malarial, common for us is the malarial parasites, right? Plasmodium group as a whole, which may be the Vivax or Falciparum, malaria or ovedi. Similarly, even Toxoplasma gondii, that is in protozoa. Even Balantridium coli, Giardia lamblia, right? All these, even the, I think for Leishmania donovani, that is also, all these are in the protozoa. Next group comes as the cystodes. In the cystodes, Tinea solium, Tinea saginata. Then I think D. latum even, and Echinococcus granulosus. This is Echinococcus granulosus for the hepatitis, which comes in cystodes. Later on, this even the Paragonus westergami for the lung plaque, hematobia, even that is the for this liver plaque, and then S. japanaki, hematobium, and even the Mansoni. These are for the different type of the schistosomiasis. Then comes the question of these nematodes and nematodes. So I think parasitology, one or two questions in the OSCE in some different forms, people are going to ask you either the X-ray or even some presentation or case scenario or something. For suppose neurocystic sarcosis, they can take the tinea sodium. Suppose B12 deficiency, they can take the D. latum, Dilophobothrium latum. So like this, these are the questions they can. So parasitology, you can prepare in this way. Okay. An infant develop this high-grade fever, irritability, and generalized erythema. Child develop peeling of the skin on touching and resulting of this type of picture.
Yes.
Staphylococcus
Staphylococcus
aureus.
aureus.
Very good. The question comes, what is the characteristic sign of this condition?
Nikolsky.
Yes, Arti, can you describe that? How will you do it?
Sir, with even on pressing, there will be peeling of skin of just.
You know that is just with your blunt object. If you try to draw the line over the skin, the whole skin sheet is separated.
Yes, yeah.
So that is the Nikolsky sign in the viva samrimas. And what is the toxin?
Epidermolysis, exotoxins.
This is the epidermolytic toxin or exotoxin. Then the people may ask you, there is the other toxin. What are the other toxins? The staphylococcal. Which are the other toxins responsible for various serious conditions?
Penton valentine toxin.
EBL.
Yes. Number who spoke, please?
Dr. Bhavna.
Bhavna, what is that? What did you say?
Penton valentine toxin.
Yeah,
Toxic
that
syndrome.
is the PVL.
PBL, sir, for community acquired pneumonia.
Toxic shock syndrome.
Let me take one by one. What the PVL does, Bhavna?
It causes toxic shock syndrome.
No.
Community or hospital acquired pneumonia, sir.
That is will be the MRSA, that is the staphylococcal. It's a different story. Any MRSA or even any staphylococcal will cause the pneumonia, MSSA or MRSA. But what toxin, suppose PVL toxin, what does it do? And what is how the patient will present, and that is very important for the clinician to know. Even sometimes you have diagnosed the case of the staphylococcal pneumonia. You are treating. Later on, there may be the complication due to this PVL toxin. How will you realize that, yes, this is the complication of PVL? And it requires the change in the treatment.
Drug resistance, sir.
What drug resistant PVL toxin? Please remember, unless you are knowing, and I'm sure that unless you have discussed, you may not be aware of it. That is a penton valentine leukocidine. What is the leukocidin? This toxin acts on the leukocytes, and leukocytes are decreased. And therefore, when the patient of pneumonia, your count was 20,000, 25,000. Now with this complication, the count is going down, 10,000 or 5,000. That means this PVL toxin is liberated. And even if you see the neutrophils will decrease in numbers, and patient is deteriorating. Radiologically, if you see, that is the necrotizing pneumonia, destructive pneumonia. And here, suppose if you suspect that this is due to the PVL toxin, what antibiotic you will add? Anti-staphylococcal agent. Which one you have to add?
Vancomycin.
Cloxacillin.
Vancomycin is already going on. I think
Cloxacillin, sir.
Sorry?
Cloxacillin, sir.
Cloxacillin, in which type of the staphylococcal you will give it?
MSSA.
Yes, MSSA, methicillin sensitive. Please remember,
Vancomycin.
please remember, anti-staphylococcal agents may be the short note in your exam. And that I will say many a time people are asking, at least in ID chapter we are asking. And here also in the DNB, anti-staphylococcal agent, and you should have a very clear explanation. Starting from the amoxicillin to the cephadroxil, due to the cephalaxine, to the cloxacillin, to even the vancomycin, to the teicoplanin, to even the linezolid, to even the clindamycin, so many drugs, and every drug is having the very appropriate place. With the PVL toxin, add this clindamycin. Clindamycin is a PVL toxin blocking agent. And which is the another drug which will even block this PVL? Only two anti-staphylococcal agents. One is the clindamycin, second is linezolid. Suppose already I have started this vancomycin and my blood culture has shown even the MSSA. What I will do? Aarti? I hope that you got my question. Suppose a case of pneumonia. I have taken the blood culture. I have started with the, because MRSA is very common and patient was not in good condition, I started even the vancomycin. Now the blood culture report is there with me and it shows the MSSA. Should I go for any change of antibiotic or continue same? What is your answer?
If patient is responding to vancomycin, we'll continue with the same, sir.
Okay. Smart answer.
We'll check for the sensitivity pattern and would like to add clindamycin along with vanco.
I think super smart answer, Sam.
So we should continue.
But the basic answer is unanswered. Yes, Rajat.
So we have to continue with vancomycin so that drug resistance doesn't develop. And if it is MSSA, it will definitely respond to vancomycin as well.
That's why I have asked the question. And I think I have succeeded in asking the question. What is my question? In MSSA, which one is superior? Vancomycin or cloxacillin? Or linezolid? Which one is superior? Bhavna?
Linezolid superior.
Very common answers. Please remember here, for MSSA, cloxacillin is the superior. Vancomycin is inferior to the cloxacillin in MSSA. That should be the answer. Even cefazolin is better. But vancomycin is good for the bacteremia and the MRSA. But for MSSA, my cloxacillin is superior to the vancomycin. Usually we have the impression that vancomycin is the final answer in staphylococcus, but it's not so. These are, I will cover so many questions, which probably that may be on viva, table, drug, anywhere they can ask you. But even in the X-ray, suppose some lung abscess, then they can ask these questions. So that's the thing. Anyway, let us go further. Name the drug to treat it. Here, I think here the yes, any cloxacillin plus clindamycin or vancomycin plus clindamycin. Because here we are not sure MSS or MRSA, so clindamycin, but for the toxin blocking, Clindamycin has to be there. That is very important answer. Other toxins, toxic shock syndrome. What is the, I think Bhavna was answering. Bhavna, what is the toxin responsible for toxic shock syndrome?
Enterotoxin.
No. Okay, then enterotoxin, what it does, Rajat? Viva is going to be like that. Whatever you give the question, answer that the examiner will frame the question.
Enterotoxin is pseudomembranous colitis.
Enterotoxin from the staphylococcal will cause either the pseudomembranous colitis or colitis, right? Or even the food poisoning. Staphylococcal can cause the food poisoning, right? But the answer for the toxic shock syndrome is the toxic shock antigen or super antigen.
Super antigen.
In the Nelson, the name is given super antigen. So please remember the different toxins by the staphylococcal. They are responsible for very specific. Even one more toxin, what condition you want over the skin specific, like this staphylococcal scarlet skin syndrome. Another condition more with the skin manifestations by the staphylococcal. More common with the streptococcal, but yes, staphylococcal can also cause scarlet syndrome. Scarlet syndrome can also be there due to the streptococcal, more common with the streptococcal. Anyway, this is 2-year-old child with the scabies. Generalized lymphadenopathy, you can see the inguinal, the diffuse lymphadenopathy. Failure to thrive, test for systemic infection was positive.
So this is Norwegian scabies, most likely.
Norwegian scabies, immunodeficiency, sir.
First question, what is the systemic infection?
HIV.
Very good. HIV or AIDS. Even just 10 days, 5 days back, I had one patient from Mehsana for recurrent ulcers. For 6 months, somebody had done the biopsy, surgeon. I came to, there was the oral thrust, turned out to be the HIV. So HIV is not out of this, I will say, practice. Please keep in mind. Which variant? Somebody answered even before I put the question. Norwegian scabies. And which is the drug?
Ivermectin, 0.2 mg per kg, OD state.
Okay, very good. Name the mite causing the scabies.
Sarcoptes scabies.
Okay, good. This is an 8-year-old male child. Difficulty in chewing and swallowing. And there was the injury. Not vaccinated. Spasms or disturbance.
Tetanus.
Very good. This is a good revision because these questions were done few months back. So it's a good, I will say that I at least understand that you do remember. Very good. I may not go into the details of all these questions, but tetanus also please keep in mind. Okay. Look at the pictures. I think not uncommon in the practice.
Hand-foot-mouth disease.
Absolutely. Hand-foot-mouth disease. Very good. The question is, most frequent positive agent?
Coxsackie A16.
Coxsackie A16.
A16.
Right. And what other organisms are known to cause it? Please remember A, B, enterovirus and even ecovirus. The question is, what are the known serious complications of this disease? Commonly not serious disease, but uncommonly serious complications are known, which we should be aware of.
CNS manifestations like aseptic meningitis.
Okay.
Or pneumonia.
Okay. Please remember myocarditis, pericarditis, shock, encephalomyelitis, pulmonary hemorrhage, and all these complications are more so with the enterovirus 71. This may be the OSCE station question. This is more common with the enterovirus 71. This infant had the deformities of the limb since birth. X-ray revealed the diagnosis.
Osteogenesis imperfecta.
Very good. Arti answer?
Yes, sir.
Okay. Question is, osteoimperfecta, what is its inheritance pattern?
Autosomal
Autosomal dominant. Next question, what is the clinical triad of this disease?
Blue sclera.
Very good.
Early deafness.
Yeah, hearing loss, deafness.
Yes, fragile bones, blue sclera, and the deafness. And what is the biochemical defect?
Type 1 collagen synthesis defect.
Very good. The collagen formation defect, even if you say, then also people will consider. What are the medical treatment options? Now you know that the treatment is available.
Sick above
Biphosphonates.
osteotomy
Biphosphonates.
and
Okay.
bisphosphonates.
One is the
Growth
growth hormone now. This is the now permissible use of the growth hormone in achondroplasia, osteogenesis imperfecta, even the chronic renal failure, even the low birth weight baby. These are the few conditions where growth hormone is now approved for use. And another, yes, as Aarti was telling, biophosphates, and these substances are now available. 12 years old girl presented with obesity.
Acanthosin,
Very
PCOD.
good, very good. Please remember, this is not uncommon. Acanthosis nigricans. What is your clinical diagnosis? So you know the
PCOD.
polycystic
PCOD.
ovarian disease. Investigations. What investigations?
So we'll have to screen
Yeah.
for diabetes as well because it's a sign of insulin resistance.
Okay.
So FPSL,
PCOD profile,
RPSL,
sir.
HbA1c,
Luteinizing hormone.
and USP.
Luteinizing hormone.
Please
FSH.
remember,
profile and
please remember this
CF.
investigation. FSH, LH, prolactin, dihydroepiandrosterone, estrogen, progesterone, testosterone, sugar, insulin, lipid profile, thyroid function test. Even this can be the full question in this theory also. But theory now you have completed, no problem. To what condition this patient has increased the risk?
So diabetes,
Yeah,
type
Yes,
other
hypertension,
autoimmune disease.
coronary,
hypertension,
even the infertility.
Infertility.
Yeah, particularly in the females. One more question. Here it was this is the radio imaging. This type of the question is also common in the OSCE. 8 years old male, illness of 18 months, headache, vomiting, gradually increasing, difficulty in vision, but no fever. On fundus papilledema, proportionate short stature, CT scan of the brain was performed.
Craniopharyngioma, sir.
Okay. Why?
Sir, about the location, it's in the ventricles, lateral ventricle.
Okay.
proportionate
And
short
about the age
stature,
and symptom.
What you are able to see in the CT scan?
calcified mass,
Calcified mass.
Yes, and what else?
Hydrocephalus.
And
Yeah,
optic asthma.
hydrocephalus.
Optic asthma, I can't see the CT scan. So CT findings, cystic swelling, calcifications in the suprasor area, development of hydrocephalus. What embryonic structure is represented in this disorder?
Ectoderm.
What embryonal structure is represented in this disorder? Anybody? Bhavna, Aarti, Akshay, Sayan, Rajat, and others.
Redcase pouch.
Redcase pouch. What endocrinal disorders are known to occur in this disease? You know, this disease can occur with the various the disorders, endocrinal, and it is known with the related to pituitary disorder. Precocious fever, even diabetes insipidus. Even Dr. Udani, Brajesh Udani's father, he reported these disorders with the involvement of pituitary in a case of tuberculosis. So the things are known. I think you should be clear. 9 years old male, diplopia. And you can see the picture on the left side to me. Then rapid fatigability. Second picture is after the administration of some drug.
Myasthenia gravis.
So this is myasthenia gravis. And myasthenia gravis can be the full question in the exam. What is the site of lesion?
Neuromuscular junction.
Neuromuscular junction. Which drug is administered for clinical testing?
Edrophonium.
Okay. And what is the dose? Somebody may ask. Penicillin is the name. 0.1 to 0.0 milligram, maximum 10 milligram. Which drug should be available in the syringe ready for IV administration at bedside during this clinical test? Very important because the complication is known.
Atropine.
Okay. Atropine should be there. Neostigmine is the derivative of same physostigmine. So atropine, because muscarinic effect to block it.
Okay.
And therefore atropine should be there, and many times it can be the serious complication. Now here, age is 4 years, weight is only 10, height is 82, calcium is 5.8, phosphorus is raised, alkaline phosphate is chi rays, parathermal is rays. Now the questions, Aarti, what is your clinical diagnosis?
Rickets.
Vitamin D
Rickets.
resistant rickets.
Yes, Bhavna. Akshay, I think, are you there or not on the screen?
Yes, I'm here.
Yeah,
Hyperphosphatemic rickets.
okay. So one answer. We'll go for the multiple choice question.
So, whether it is a vitamin D dependent or resistant, that will come to know on serum 25-OH-T3 the levels.
But from the clinical picture, you can suspect.
Alopecia is there, then
Alopecia there.
Okay,
So-
alopecia is there. Aarti said. Am I right,
So
Aarti?
most commonly, sir,
Yes, yes.
X-linked
Vitamin D
dominant
resistant.
hypophosphatemic rickets.
So let us, in clinical picture, when they are giving, there must be some obvious reason. Here, suppose she said the alopecia, then alopecia is with which variety it is common?
Vitamin D resistant rickets
Vitamin-
type
Yeah.
2.
Yeah. Right. So vitamin D dependent,
Yes.
it's not resistant, it's a dependent. Type 2. And in the type 2, the alopecia and sibling involvement is very common. So there may be the point. What is the expected level of 125 hydroxycholecalciferol?
High, because it's a receptor resistant.
Absolutely, absolutely. Here the level is going to be high, but because receptors are not sensitive, it is blocked. Therefore, the effect is not available, and it is going to be elevated. What is the basic defect? Already we discussed. End organ resistance to this, that is the receptor blocking to this substance. And what is the pattern of inheritance?
X-linked rickets.
X-linked recessive.
X-linked dominant.
Autosomal recessive.
X-linked
Is it?
dominant.
Is it? So I think now the multiple questions answers I have there. Autosomal recessive, autosomal dominant, X-linked. So what's the answer? It's an
Dominant,
autosomal
sir.
recessive. It's an autosomal recessive. Autosomal recessive. One more question, I think very common, but this can be the short, even I would say spot case, even the OSCE or anywhere they can ask you. What is the clinical sign I have tried to show in this picture?
Sunset
Sunsetting
sign.
sign.
Sunset
Okay.
sign.
Hydrocephalus.
But the question is going to be there. What is the mechanism of this sign? Why this develops?
Blockade of CSF pathway, sir.
So I'm asking for the setting sun sign. That means which mechanism causes the setting sun sign, setting sun eye sign?
Sir, oculomotor nerve
Oculomotor.
involvement due to
Yeah.
causing LRs
Pressure
and superior
effect
oblique
on the
ulcer, lateral
agitator.
Let me interact with my one. Bhavna, suppose oculomotor is involved. What will be the other manifestations? And in the oculomotor, which muscles will be involved? Which
Sir,
will
all
cause the
extraocular muscles except LR and SO, lateral
Superior.
rectus and superior.
Sir, optic chiasma compression.
by the optic the chiasma compression, this will be the setting sun sign. Or in other way, what are the manifestations of optic chiasma involvement? Please
Sir,
remember.
Bitemporal
pineal
hemianoplasm.
gland
Or,
will compress the optic chiasma.
The optic chiasma involvement is not responsible for this. Optic chiasma will cause the loss of vision.
Hemianopic.
Please understand and then answer. Optic chiasma will cause the loss of vision in the various parts, which would be the characteristic. So the here reason is impingement of the dilated suprapineal recess on the tectum. That is the anatomical length point is quadrigeminal plate. So here what is lost now? Upward gaze is lost. In the hydrocephalus, there is a loss of upward gaze. Child is not able to turn the eyeball upward. So that's the reason. Name the sign elicitable on percussion of skull in this condition.
McEwen sign. McEwen sign.
McEwen sign.
McEwen sign.
Bhavna, can you explain what is during which age I should go for this McEwen sign or the crackpot sign? Is there any specific
Yeah.
age or at any age?
After closure of the
After
anterior
closure of
fontanelle.
anterior fontanelle.
Okay. Then after any age, later on, suppose the AF is closed. In adult, can I do? Suppose 20, 21 years old person or 30 years old person.
Up to 18 years.
Up to 18 years, why?
Yes, all the sutures meant to be
Suture-
sutures are closed.
Sutures are already closed. If you say 2 years sutures are closed. So please remember, this sign should be done between 2 to 18 years. 2 years sutures are closed, but they are not ossified. And therefore, with the raised pressure, there is the scope of separation. And therefore, the crackpot sign develops. After the age of 18 years, the sutures are ossified. Now there is no scope of separation. So no chance of development of the crackpot sign or Meseval sign. So this sign is going to be present between 2 to 18 years of age. Please remember, very good point for this Meseval sign. Okay. Which regular follow-up examination often indicates this condition at the earliest?
Head circumference monitoring.
Very good, very good. Which probably I think answer is there, but hardly the round it is seen. Am I right, Bhavna? Bhavna answer, I think. Yes or no, Bhavna?
Yes, sir.
Yeah, you answered so tell me. I'm sure that what I mean that doing this board also. I wish that all of you should be there in my round so that I can enjoy with you. Anyway, serial measurements. Next question. Please remember, any these are the syndrome, there may be the OSCE station. Here is a 7 years old maid, massive lymphedema, you can see. Short stature and webbing of neck.
Noonan syndrome.
Noonan syndrome.
Please remember, very good. It's a Noonan syndrome.
Male.
What is the another name of Noonan? What is the another name of Noonan syndrome?
Turner syndrome.
Yes. Then what do you call it? It's a male
Pseudo
Turner.
Turner.
Male dome.
It's a male Turner.
Male.
Not pseudo Turner. It's true Turner, but it's the male. Right. What is the most common cardiac anomaly?
Pulmonary stenosis.
Pulmonary stenosis. What is the most common cardiac anomaly in a case of Down syndrome?
Endocardial cushion defect.
Endocardial cushion defect.
What is the most common cardiac anomaly in a case of Williams syndrome?
Supravalvular
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 aortic stenosis.
aortic
Okay,
stenosis.
what is the most common cardiac malformation in a case of infant of diabetic mother?
Asymmetric septal
TGA.
hypertrophy.
Transposition of great vessels. Okay. And what is the most common cardiac malformation in Edwards syndrome?
VSD.
What is the most common cardiac malformation in Patau?
Same VSD more
Same.
than.
What is the most common cardiac malformation in Turner?
Bicuspid aortic
Bicuspid
valve.
aortic valve.
Is it?
And
Subaortic stenosis.
Coarctation of aorta.
Coarctation.
Coarctation aorta is the most common. And what is the most common malformation as a whole?
VSD is most common.
Yes.
That is the most common answer, and it is not the right answer. What is the most common cardiac malformation? You know what is the definition of cardiac malformation? Cardiac anomaly? Somebody asked you what is the
Bicuspid
definition?
aortic valve.
Okay, bicuspid aortic. Who said?
Dhaval.
Dhaval. How did you say bicuspid aortic valve?
Sir, somewhere I read it. It's the most common.
Okay, good. Wherever you have read it, it's a good answer. As in the KBC, Amitabh is asking that where you have read, I think you are right. Anyway, what is my question? Cardiac malformation is a cardiac anomaly which may be structural, which may be functional, which may be positional, which is present since birth, which may manifest at any time, or which may not manifest any time in the life. That is the cardiac malformation. And bicuspid aortic valve is most common without malformations. But in which conditions, suppose bicuspid aortic valve is present in the person, there will be complication. What complication can develop? Suppose the person is having the bicuspid aortic valve and he develops, suppose, even in the adult, myocardial infarction, or in the children, develop the myocarditis, or these types of some disease, then complication rate is high. Which complication will develop?
Pulmonary artery hypertension, sir.
We are talking with the aortic valve.
Aortic regurgitation.
Aortic regurgitation is most common. And therefore, any person with a healthy heart develop this type of the complication, suspect the bicuspid aorta. In the echo, you will get it. Okay. This is just related, some answers came to my mind. What anomalies of external genitals are common in this disorder? Small penis, or even the cryptoplegia. Small penis is most common in this syndrome. Anyway, this is ECG. This is one more variety of the question. Let me take one by one. Akshay, would you like to answer? A patient of acute renal failure presented with generalized weakness. Pulse was irregular. Urgent ECG was perceived, and this is the ECG.
There is tall hyperkalemia.
Okay, it's a tall peak tented T wave. Please remember, these three adjectives for T wave. They are tall, they are peaked, they are tented, very sharp. Otherwise, in the diastolic volume overall also T is going to be raised. But they will be slow, rounded. Here it's a tall, peak tented T waves. And it is due to the hyperkalemia. The question is, what are the other ECG changes of this condition? Besides T wave?
Narrow QRS.
Okay.
Prolongation of the PR, prolongation of the PR interval.
Is it, Rajat?
No.
ST elevation.
ST elevation.
Okay.
Inverted U.
This is the answer. ST, not elevation, but depression.
P wave.
Prolonged PR interval, yes. Flattening of P waves and widening of the QRS complex. Widening of QRS complex is very important. It is even, it may be the fatal. Suppose if widening continues, at some time there will be the
ventricular tape.
Yeah. Mention the line of the treatment, very important. First one, even order should be very clear.
The first we gave injection calcium gluconate to stabilize the myocardial mechanism.
Absolutely, very good. 10% calcium gluconate, 0.5 to 1 ml per kg diluted IV slowly under cardiac monitoring. Please remember every word. What is the strength of the calcium gluconate available in your routine ward? Bhavna? Akshay? The calcium gluconate which is available in your ward, what is the concentration per ml?
100 mg per ml.
Please check it. And again, if I remind you, please prepare for this adrenaline, prepare for the calcium gluconate, prepare for the soda bicarb, prepare for the methylprednisolone, prepare for the immunoglobulins, because these drugs are going to be there on the table. Okay, what is this? Orchidometer. Okay. The question is, what is the unit of measurement of this organ?
ml. Testicular volume in milliliters.
Testicular volume.
Yes. And what is the different age group? Please remember. Infantile 2 ml, prepubertal 3.24 ml, adult 70 to 20 ml. So I think that we should know, particularly with the testicular size in the puberty and prepubertal different stages. This was the 6-year-old female, consanguineous parents, painful swollen joints. And even there was mental retardation. No rheumatoid arthritis. It was diagnosed by somebody, but it was not rheumatoid arthritis. and biopsy of the nodule confirm the diagnosis. Very rare condition. Sometimes they will keep in the OSCE one, very rare condition, to test the some of the students. What is the disorder?
Dermatomyositis.
Okay. Which one? No problem. Who said? Please continue. Who said? No problem. Dermatomyositis, I think.
That's cyan.
Cyan, yes. The question is, how even the exam, the viva starts. What are the common presentation of dermatomyositis?
Sir, it will be
heliotropic rash, Gauthron's papule.
Bhavna, this is on examination. What will be the complaint of the patient? How they will come to you?
Sir, fever.
Usually weakness in the bilateral lower limb.
Okay, what type of the weakness?
Proximal muscle.
proximal muscle.
Patient is complaining difficulty in climbing the upstairs, difficulty in getting up from the low sofa. Even my slippers run away from my foot. These are the complaints, or difficulty in raising the shoulders while combing the hats or removing the shirt. So these complaints, that means it indicates the proximal muscle weakness. And such a patient, if you see later on, you will get the various presentations, as already Bhavna was mentioning, some of the markers that they got transplants and these changes, okay? But not these type of nodules, right? So here nodule is a characteristic, and you can see the extensor aspects particularly. Even in the back you can see, I hope that you are able to appreciate all this spine. Right. This is rare, therefore I say it's a Farber disease.
Farber's disease.
Please remember, Farber and Fabry, both are different. And Farber's disease, name the enzyme deficiency, that is the lysosomal enzyme ceramidase. And due to what? Hoarseness of voice and breathing difficulties develop in this disease. This patient, even hoarseness of voice and difficulty breathing may be the problem. And that is due to the nodules. Some people may ask you, in which condition there will be the hoarseness of voice, even other conditions?
Hypothyroidism.
Hypothyroidism, yes. Laryngitis, even some laryngeal mass, papillary polyp, laryngeal polyp can do. Right?
Pharyngeal space sepsis.
Yeah. What causes the death in this condition? Recurrent pneumonias. And the point is, I'm not sure whether I kept the question. No question. But now the enzyme replacement is available for this disorder. And then the question will be there, what are the other enzyme replacement therapies are available? Which other conditions? Yes, Gaucher's disease enzyme replacement is available. Pompe's disease is available.
Pompe's.
Even this enzyme replacement is available. If others are there, I'm not sure, but these two, yes. And even our own country, people are doing. Here it was a 2-year-old female, failure to thrive, anemia, sphenohepatomegaly, picture of bone marrow. What does it indicate? Which condition? I think I have given the clinical picture. It's a 2-year female, failure to thrive. Anemia is main, and even the huge is hepatosplenomegaly. I have done the bone marrow, and this is the picture. And for what already we discussed, that the enzyme replacement is available.
Gaucher's disease.
So it's the Gaucher's disease. Which enzyme deficiency causes this disorder?
Glucocerebrosis.
It's a lysosomal hydrolase or acid beta glucosidase. Describe the cells, the Gaucher cell in the bone marrow. How will you describe? What type of the cell it is?
Crumpled tissue appearance.
Yes, it is size 20 to 100 micrometer in diameter, wrinkled paper appearance, dirty even. What are the treatment options? Already we discussed, enzyme replacement, even bone marrow transplantation. Yes. Common condition in the pediatric practice. 8-year-old female, fever, joint pain, pain in abdomen, rashes, as per the photograph.
HSP.
Yes,
Yes,
anal
sir.
Anal
swelling.
swelling purpose.
What is another name of HSP? Now the terminology change. In 21st edition, some other name is given. Anybody? IgA mediated small vessel leukocytoclastic vasculitis. This is called as IgA mediated small vessel. This is the small vessel vasculitis. And here leukocytoclastic vasculitis. This is the newer name of the HSP. Whether these petechial spots will be palpable or not palpable.
Palpable.
Why palpable?
Palpable purpura.
Okay, why palpable? Arti? ITP, is ITP palpable or not palpable?
Not palpable.
Yes, that is the main difference. ITP not palpable, HSP palpable. So when the HSP palpable, which mechanism is responsible for making it palpable?
Deposition of the IgA.
Very good. Smart
And it's a
answer.
vasculitis, whereas in ITP, it's a thrombocytopenia.
That is right, but what mechanism
Sir, there
makes
will
it?
be a edema formation in the intervascular spaces.
Absolutely. Rather than that, it is the inflammation. And inflammation causes this swelling. And therefore, it becomes palpable. Right? What is the cause of pain in abdomen in this disorder?
Mesenteric ischemia.
Yeah, superior mesenteric.
Again vasculitis. Right? And vasculitis and ischemia of the intestine. What emergency surgical complications are known to occur in this disorder?
Thromboembolism, stroke.
Acute ischemia of the bowel.
Okay. Anything else? Surgical conditions, an emergency.
Intestinal obstruction.
Okay. Obstruction due to what? Obstruction due to what?
Mesenteric arteries are that
Please
supply.
remember intussusception. That is called the obstruction, but intussusception, bowel perforation, and even testicular torsion, what we discuss. HSP is known. So these are the surgical conditions. I think very nicely in the last few lines Nelson has given. What is the another major complication of this disorder? Major, which will make the difference. Yes, which will make difference in the prognosis of the patient. And that is the renal involvement, nephritis or nephrosis, what we say. Very classical clinical picture.
Colloidal baby.
Yes, this is colloidal baby. Describe the characteristic of the disorder seen in this patient. Which characteristic you are able to see? You can
So there's
see
a colloidal membrane which covers the entire body, is enclosed in a membrane with mucosal ulcerations and mucositis.
You can see the oral cavity. You can see the eyes. These are the characteristics. Oiled parchment skin, then ectropia. Eyelashes, if you see ectropia. Fixation of the lips in the O-shaped configuration. You can see the O-shaped oral cavity. Very classical. I hope that you are able to appreciate. This is this type of the things. Even ectopian, child is not able to close the eyes, and the eyelashes will remain upward. Ectropia. So this type of the one skin condition, commonly they are keeping in this OSCE. What morbidities are common in this disorder?
Superadded infection of skin,
bacterium.
Absolutely,
dehydration.
cutaneous infection, aspiration pneumonia, hypothermia, very good, and hypernatremic dehydration, very good. Okay, one more syndrome. 10 months maid, presented with regression of milestone. Dysmorphism you are able to see, I think quite obvious. But the size of the head is large, macrocopeny. Scleroid blue, but hypotonia but DTR brisk. And high concentration of some metabolic substance in the urine and blood was diagnostic. This is some metabolic disorder. Which one?
Wilson.
You can see that the head is larger size. Look at the ears. Very classical. Look at the shape of the head, even the face, and the scleroid blue.
Ehlers syndrome.
This is very classical.
Denavans.
It is a glutaric aciduria type 1. It's a metabolic disorder. And what metabolic substance is likely found in the urine or blood? That is glutaric acid. And name the group of metabolic disorder in which it is classified. It is organic aciduria. What deficiency is the cause of this disorder? Glutaric coenzyme A dehydrogenase. Please remember, the metabolic disorders are more than 400 to 500. And some metabolic disorders are now not uncommon in the practice. So common, at least we should know. And some this type of variety, they may keep in the OSCE. Spot diagnosis. Presented with short stature, intellectual disability,
Cornelia de Lange.
yeah, bushy eyebrows and upturned nostril. You can see this is very characteristic. Nostrils are upturned. And even you can see these brushy eyebrows, even as our hirsutism. So some syndromic condition, they may keep it. Spot diagnosis, Cornelia de Lange. Anyway, this is the fundus examination. This is again these are the question OSCE they keep. That's why I selected various to give the idea. In fundus, any type of the picture they can keep it. Here it was the 18 months male. They can keep the papilledema, they can keep optic neuritis, they can keep the different, but the fundus common conditions you should know. Here it was the 18 months male, regression of milestone, conversion. All these pictures I have taken were real, my patient which I have seen.
Sir, cherry red spot.
Cherry red spot.
For storage disorder.
Okay, cherry red spot. I think question is, name the conditions with this ophthalmic finding. In which condition?
GM1 gangliosidosis.
GM1 gangliosidosis.
Tay-Sachs disease, Sandoff, gangliosidosis. Actually, cherry red spot, that means the red spot is due to what?
That dilatation of the ophthalmic.
It is basically deposition of the lipid pigments beneath the choroidal layer, and
so the red spot which is seen is due to the deposition. Am I right? Am I right, or some other thing? Please remember, this is the most common mistake. Actually, this cherry red spot is normal. The surrounding halo is due to the deposited substance, which makes this spot very prominent. So deposition of the substance is over here. This red spot is not the pathology, but it becomes obvious to see, right? So this is just to understand. One more question like this. 45 days old male child presented with severe anemia, thrombocytopenia, hypocalcemia, hepatosplenomegaly, and severe sepsis.
Osteopetrosis.
Very good. Osteopetrosis, yes, marble bone disease. What is the cause of hepatosplenomegaly?
See, infiltration of the reticular endothelial system in the bone marrow by the osteoclast cells.
Wow, Rajat.
Very good sequestration.
Rajat, very good explanation. I think examiner will have to open the book. Anyway, but always speak with confidence. What happens in a case of anemia, Aarti? To liver and spleen, any condition? You know, here, in a case of thalassemia, why there is liver and spleen are enlarged?
Sir, there will be destruction of the
RBCs.
Please, not due to the destruction of RBC.
Splenic sequestration.
It's an extramedullary erythropoiesis. Why do you forget? It's a basic question. Even in iron deficiency, severe iron deficiency, there may be splenohepatomegaly, 10 to 50% cases. The reason is, if it is severe one of longer duration, this extramedullary erythropoiesis starts. In the fetal stage, liver and spleen were the sites from where the hemoglobin was synthesized. Am I right?
Yes.
Yes.
So now later on, this function is taken up by the bone marrow. But when the crisis develops, the original, I would say, primitive structures start to function. And therefore here, in a case of what happened, that bone marrow is replaced by the osteopetrosis, this osteoclastic cells. So now marrow is not able to give the service. Therefore, the liver and spleen are enlarged, and that is the compensatory extramedullary hematopoiesis. Please remember. Now, why is this? There is a dysfunction of optic nerve and facial nerve. In this condition, very common. Even the child will present with the blindness. This X-ray which I have taken is the real patient. From the Vistnagar I received many years back.
The infiltration by the osteoclast.
But what happens to the optic nerve and facial nerve? There may be the facial nerve palsy. There may be optic atrophy. Due to what? Anybody able to think? Arti, Bhavna?
Sir, there
Akshay-
might be
Akshay?
sclerosis of the bones compressing the nerves.
You know, that is a narrowing of this foramina.
Sclerosis.
And this then there is the compression effect of these nerves. And therefore, they lose their function. So narrowing of foramina. What can be offered as a treatment? Now again, the treatment is available. Please remember, here is the problem osteoclastic. Therefore,
HSCT.
one is the bone marrow transplantation, calcium
Hematopoietic
can be
stem
anyone interferon gamma they have tried. So these are the questions may be there. One more ECG. I have shown with the circle. Focus over this part. Then the questions.
P mitral.
P mitral.
Okay. P mitral. Arti, P mitral is due to what? What do you
Left
call
atrial.
what do you call this P mitral? What do you mean it by it? Anybody? Bhavna, Akshay?
Left atrial hypertrophy.
Atrial enlargement.
You don't please don't mug up. That's right. Left atrial hypertrophy, but what is seen in this? You see,
The broad notched bifid P wave.
absolutely. Now, why there is the bifid or the notch and the widened P wave? You know, two characteristics in ECG. One is the P wave is widened. What is the normal P wave duration?
So it is actually 2.5 by 2.5 small squares.
Usually two small squares, right? 0.2. Now they are widened and notched because right atrial, the P wave is formed by right atrial contraction and left atrial contraction. Now left atrial contraction takes more time, therefore it is wider. But the right atrial contraction stops early, therefore there is notching. So here there is the notching and the widening of the P wave, what we say P mitral, and that is characteristic of left ventricular hypertrophy. But you know, in the exam or viva, somebody may ask in this way. That means how much ECG you are doing. What does it indicate? As I said, absolutely left atrial hypertrophy. What are the other ECG criteria for its diagnosis? Yes, left atrial hypertrophy. What are the other criteria? On ECG, sorry. Yes, ECG. I have written the EEG, but ECG, yes. What are the other? Wide and notch P wave lead to particularly biphasic P wave in V1 and P wave duration is prolonged, 0.1 second. Right. I think normal is
0.2.
0.2. No, 0.2. It is more than 0.1. I think only 0.05 or so.
0.12, sir.
Yeah. So sorry, I don't
0.12,
remember.
yeah.
You can verify. The point which I don't know, I will not speak, so that you cannot do the mistake in the exam. Okay. This neonate has undecided testicular urinary tract abnormality. Again, the syndrome.
Prune
Prune belly
belly
syndrome.
Prune belly.
Very good. And this type of the question they are going to keep in the OSCE. This is prone belly. They say Eagle-Barrett syndrome, another name. What are the common associated urinary tract abnormalities in this condition?
Cryptorchidism.
Okay. Very good.
And bladder
Exostrophy.
Okay.
extrophy of bladder.
Please remember all these renal malformations are common. Megaureter, megauretra, large bladder, posterior urethral valve, or vascular reflux. All problems are known. And what is the known pulmonary complication associated with this disease?
Pulmonary hypoplasia.
Hypertension.
Yeah, and this prognosis depends upon pulmonary hypoplasia. So please keep in mind this Pulmonary syndrome, pulmonary hypoplasia. Okay, one more condition. 10 months old baby having the blister formation following mechanical trauma or irritation often runs since birth to this patient. I had one patient from Gandhinagar. Unfortunately, this patient died later on. But one skin condition, as I talked to you, I kept some skin conditions. The Staphylococcal scarlet skin syndrome, then the scabies, then this condition. So at least prepare some, keep some very common skin conditions. What is this? If I say the benign condition, yes?
Pemphigus.
Epidermolysis bullosa.
Yeah, this is epidermolysis bullosa simplex. Nelson has given, Merbansi has given the very good picture of this patient. I remember. He checked it. Very nicely given. And what is the pattern of inheritance?
Autosomal.
It is autosomal dominant. And what happens to nails and dentition in this condition? In this photograph, actually, I could not show this particular nail changes. It was there, but somehow in the photograph, I could not focus. You know what happens? Nails become dystrophic. Nails become dystrophic, and dentition is normal. In which condition dentition is affected? There may not be
Ellis-Wall-Crevald syndrome.
Okay, most common where the dent.
Ectodermal dysplasia.
Ectodermal dysplasia.
Now one more syndrome. The child presented with signs of raised intracranial pressure. Scholars' features were very prominent. Even from the picture you can make
syndrome. Eppert syndrome. Syndactyly maintenance.
This is craniosynostosis, to remember. Syndromes are Eppert, I think Cruzan, Carpenter, and one more. I don't know. These are the four. And what is the name of this syndrome? This is Eppert. Name the other similar syndromes, Cruzan, Carpenter, as I say. And craniosynostosis, these have some pictures they may keep it. Okay. X-ray of a term male infant present with abdominal distension.
Double bubbles.
Okay.
Duodenal atresia.
Very good. Who said Aarti or Bhavna? Double bubble?
Sir, Aarti.
Okay. Double bubble appearance, what does it indicate then?
Duodenal atresia or annular pancreas.
Very good. In which syndrome it is common?
Down
syndrome. Yeah. This is duodenal atresia. What is the commonest chromosomal anomaly? We discussed now. And what is the commonest upper GI tract abnormality associated with this? Upper GI tract abnormality. Please remember, annular pancreas.
Annular pancreas.
There are 3 children from the same family. From Panchmal district in Gujarat. Present with diarrhea and this clinical picture. All of them responded well to the treatment. What is the condition? What is the condition?
Celiac disease.
So this is rickets, but maybe secondary to RTA.
Please remember, try to focus. You can see this hyperpigmentation over nails. You can see even the feet hyperpigmentation. Even you can see the hands hyperpigmentation. Actually, the child had standing in position. Actually, it was not rickets. Do you know this girl is very straightforward? These boys are now standing in different position. Even if you say all of them responded well to the therapy. And please remember, that means some condition which is present in the multiple siblings in the family. Rickets will not be the multiple siblings in this family, right? And Panchmal district, I said, then I think you should be able to answer. That's why purposefully, I think other students from other states may not be knowing, but from Gujarat, you should be able to answer. Pinakra, it's a niacin deficiency because the maize is a staple diet in the Panchmal. And this is the which amino acid deficiency?
Tryptophan.
And which even metabolic disorder can present with this other picture of tryptophan deficiency?
Hartnup disease.
Hartnup disease. Very good. Hartnup disease. Acha, okay, I have kept over here. That is the Hartnup disease. And which metabolic disorder was found out first? Among all these metabolic disorders, which was discovered first?
Hartnup's disease.
Hartnups.
Because I asked, that's why, right? But what is the
So, no, it was a familial in the royal family. It was the subsequent generations were found.
Yeah, right. You are so knowing the history. Good. On routine auscultation, this was patient which I have seen in the LG almost 20 years back. Routine auscultation of the posterior chest of the 5-year-old child, air entry was found diminished. Patient was at hospital for gastroenteritis. Patient recovered. But on putting the statho, air entry was diminished. This is the barium study. What does it indicate? What does it indicate?
Sliding hypersonia.
Sir, this is a barium, so malrotation of the gut. But age, sir, not significant.
Please remember what will the presentation of malrotation of the gut. Whatever you answer, my question will be with the reference to your answer. What is the most common presentation of malrotation of the intestine?
Acute abdominal pain.
Acute abdominal pain.
One is the acute abdominal pain, and second, obstruction.
Vomiting,
obstruction. Okay, malrotation may be even the sometime twisting, untwisting. So even when the untwisting take place, patient will recover by its own. It may happen so. But it will not be giving this type of the clinical picture. What you are able to see, if you are able to see left lobe diaphragm is perfect, all right. Even this heart is seen. This is right side. In the right side, somehow this is also
can it be
seen.
staghorn calculus?
Sorry?
Staghorn calculus.
Staghorn calculus.
The diaphragmatic hernia.
Staghorn calculus will be in which where location anatomically? In the kidney, am I right?
Yes.
Is it kidney?
Yes. No, it is not kidneys.
Okay, Rajat is near to the answer. That is the congenital diaphragmatic hernia. Which variety then?
Bogdalic.
This is not Bogdalic.
Orgagnis, right?
Yeah.
Posterolateral.
Bogdalic, if I remind you, it will be posterolateral aspect and most common on the left side. Right side is getting the protection due to the right, this liver. But this is anterior to that, and this is called as Morgatni variety. Foramen of Morgatni variety. That is the point. And what is the name of another common similar condition? All of you know that is the Bogdalic hernia. So even this type of some radiological picture, and I'm sure that unless you have seen or discussed, they will not keep the necessarily common conditions. Sometimes they keep like this. 5-year-old boy presented with fever of unknown origin in this picture.
Syphilis, congenital syphilis. Hutchinson teeth. With that rib signs.
Presented with fever of unknown origin. That means fever was there constantly, round the year. No answer. And child was having the maximum problem in the summer with the hot days. One more hint if I give anybody, Pavna, Akshay.
Ectodermal dysplasia, sir.
Yeah, this is the ectodermal dysplasia. That is the anhydrotic variety. Therefore, there is no perspiration. Right? Name the 2 disorders commonly associated with it.
Ellis-Creveld syndrome.
Ellis-Creveld.
Okay.
GRD.
Even atopic disorders and GRD. Ellis-Creveld is different. Ellis-Creveld is not with the ectodermal dysplasia. In Ellis-Creveld, this type of some features are there, similar, but not the same condition. Ellis-1 Cribble, if you remember, it is classified in thoracic anomalies, right? That is the Ellis-1 Cribble syndrome with some cardiac malformations, deep malformations even. That is different. Immunodeficiency disorders with this condition, no. Ectodermal dysplasia. Anybody? Please remember, dysgemmaglobinemia. It is given in DELSA. Dysgemmaglobinemia is associated with ectodermal dysplasia. And I think this is the last slide. Thank you very much. I think perfectly at 8 o'clock we could finish it. One set of some other slides are also there at some other time. I think after your passing exam, when you are not the student, but probably you are some consultant or senior person, during that time we'll discuss. I have probably more than 3,400, 3,000 or 3,500, this type of the questions. And probably it covers most of the Nielsen part. I hope that at least my idea was to give you the different thoughts that whatever the some case scenario, some type of the radiological pictures, some laboratory conditions, even some radio imaging in the form of the X-ray or even CT or MRI, ECG. I have not taken the EEG, but yes, they take even the EEG also. So at least common conditions, we have to go through it. Then even some syndromic conditions. So even counseling, I think counseling is very common now. Even some of the investigations like urine and other things. So this was my different ideas to sensitize you that what type of the different varieties of questions they are keeping in your OSCE, and the same questions can be useful in your viva discussion or some clinical cases also. So I think I have tried my best to give the idea in these our 2 sessions, and I'm sure that otherwise also the way in which all of you are answering, it indicates that you are well prepared for the exam, absolutely well prepared. Keep the same tempo. I will say take sufficient rest on the previous day of the exam. Don't go for the lack of sleep. Then you should be with the presence of mind. You prepare even your, find out your apron, get it clean and even the press. Even prepare the kit for the examination. And without any hesitation, when you are talking to the examiner, I think your answer, at least you should be responding to the questions. Many times what happens, the students are not speaking. That's the problem. Suppose your answer is wrong, does not make much difference. Nobody can answer all the questions rightly. Even I think, I'm sure you can ask me the 5-10 questions. I may not be able to answer any of these. Does not mean that we don't know the pediatrics. An examiner's idea is not to find out that how much you don't know the pediatrics. On the contrary, examiner wants to know that how much you know the pediatrics. And this much is sufficient to pass the exam or not. That is their, I would say, idea. And with that idea, they are going to ask you the exam. Right. So please keep in mind these points, and I'm sure that you are totally well geared up, and it should be quite useful to. Again, my best wishes to all of you. And I'm sure that you will do better or even the best performance in the exam. With this, even Nihal, this is over to you.
Thank you so much, sir. It was very helpful session. Thank you, sir.
Thank you, sir.
Thank you, sir.
And still, I think if you find any problem or question, I think my number is there in the group. You can put it. I'll be most happy to answer. Right.
Thank you, sir.
Thank you so much, everyone.
Second year
Thank
resident
you.
me to join in the chat, sir. Thank you, sir.
Yes. Thank you and good night.
so much,
Good night.
sir. Thank you so much, sir. And sorry
Oh.
for the background noise. I'm outside, so there is a lot of noise. Thank you so much for conducting the sessions for students. And students, all the best.
There, I think I'm not the person to get this. I would say thanks or some good words from the students. It is. I'm always enjoying And I'm learning also even when interacting with all of you. So I think it's a good opportunity for me also. On the contrary, I should say thank you very much for giving this opportunity.